together, we can move the needle from chronic disease management to optimal health. And when I say we can, it's really we must. Because the healthcare system today, as it exists, is not going to be able to do it. How many people know of a clinician that does full-time preventive medicine? Full-time, anybody? Know anybody that just says, I only do full-time preventive medicine? Do you know anybody? No. Why? Because there's no CPTC code that's going to allow that physician to make a living off of prevention. Period. It doesn't exist. We have an opportunity, a unique opportunity to exactly do that. If you think about it, we actually collectively can do exactly that. When I say over the last 4 or 5 years, we've been talking about how we shift from acute urgent care to chronic disease, right? I mean, anybody can take care of a sore throat or laceration or bronchitis or a UTI, but the point is, how do we get that patient back in the doors to say, now let's talk about your smoking habits, or let's talk about your blood pressure problem that we've never talked about. So we're obviously talking about shifting from acute care to chronic disease management. But there's two principles to get to optimal care. I've been dissecting this out in multiple ways. In my head, as simple as you can get, we need to do two things. If we can understand that this is 2020, and sometimes we forget, and the reason I say that is because some of the tools that we use today is 50 years old, 20 years old. It's outdated, yet we still use it. Not because of any other reason, because we're creatures of habit. We've been using it, it works, but it's outdated. Think about the definition of diabetes or hypertension. If you ask a layperson in the hallway here, what is hypertension? High blood pressure. What's sugar? High sugar. You ask one of us, then you say insulin resistant. It gets a little sophisticated. Then you ask an endocrinologist, he'll get even more sophisticated. But the reality is, if you start getting to the root cause, is where we need to be. So one is our tools are old, okay? And two, we don't even know how to define a disease. Think about it. Does anybody really know a definition of hypertension? I don't. Maybe you guys know. Diabetes, other than high sugar, insulin resistant, we don't really know, we don't define it, even though we can, but we just never got into it. So the reality is, disease is nothing more than signs and symptoms. It's a constellation of symptoms. We bucket it together and we say, you have high blood pressure. We bucket this, you have diabetes. We bucket this, you have depression. It's not really the actual cause, right? So we need to actually forget the current definition, and it's 2020. We need to redefine what these diagnoses are. If we can redefine these diagnoses, then what will happen is we'll then start looking for why the problem occurred in the first place and not treat the what. The what is treating the blood pressure, right? I mean, like I said, I don't have to be an MD to manage blood pressure. I really don't. I have 5 drugs in the ER. I can titrate either one of them. It doesn't take rocket science. I always tell anybody, what blood pressure do you want? I can get it there. Tell me what you want. If you're 220, I can get it to 118 precisely if you want it in the next 3 hours. But that's still not solving the problem. You're just looking good to the eye. The monitor looks good. Patient's happy. Everybody's happy, but you have done squat. So we got to realize that everything we talk about, we're always basically saying, let's treat the number. I'm not saying don't treat the number, but that's not where we stop. And usually we stop there because it's easy to stop there and everybody's happy, right? The patient's happy, the nurses are happy, you're happy, and the CMS actually has a checkbox that says if the A1C is perfect, it's good, but that's not the solution. That A1C being normal is just the beginning of saying that it's controlled, but doesn't mean it's gone. So this is a 47-year-old, basically comes into your clinic center tomorrow or yesterday. She's basically coming in and you think maybe she's got some coronary risk factors, maybe she's weight, blood pressure, whatever, some of the associated numbers that you have tied in with her. So you want to get a cardiac risk score. So what do you do? She's going to walk out of your office in the next 20 minutes. What will you tell her that your risk score for a heart attack in the next 10 years is X percent? What tool are you going to use? Yeah, exactly. Framingham study. So you actually can now go into an app and pull up a Framingham study, right? Anybody done that? Calculator. So the last time you used it was when? Last 10 days? All right. So the last 10 days, you have told somebody an inaccurate information. Absolutely a false statement you made. Absolutely. Framingham study is 1948. This is 2020. So here you are in the patient's room, you pull out your iPhone, you look like the coolest doc in town, you're like punching this in, and say you have a risk score of 5% or 2% or whatever, right? So now you have this lady that walks out of your office with a false illusion that she has a 2% chance of having a heart attack in the next 10 years, so she's going to go buy a bag of potato chips now on her way home. So, and the reality is, the risk scores that are in the Framingham study, then they had a modified version that came out in 1990. So even the modified version doesn't have all the risk factors that we know of today. Okay, there's things that we can do today that's a lot better than the 1948 risk score. So what can we do? And we'll talk about that even later, but my point is we're using old technology. We got to understand, we don't know how to define it, number one, and when we do define it, if we define it right, we're using stuff that doesn't work. And not only that it doesn't work, we're actually giving false information and falsely satisfying the entire system. So, standard of care. So, I've always said standard of care is the minimum care that you would want to do to stay out of trouble. That's how I define standard of care. What's the minimum thing you need to do to skate by and not get in trouble? And so if you really look at it, if you were in the real outpatient fee-for-service world and CMS was actually, you were checking off the guidelines for CMS saying, is the blood pressure met, is the A1C met, and all these parameters that they want you to meet, you would have met most of the parameters, yet the patient's not healthy. But those are the measures that we are expected to report, so we falsely think that's okay. That's just the beginning. So it's really meeting the standard of care. So if you said, my patient's A1C is 6.2, then CMS is saying, congratulations, we're going to give you your 2% PQRI money, and you did an amazing job. Hurrah. But the reality is, you've done nothing. You've absolutely done nothing. If you have a compliant patient, do you need to be an MD to bring your A1C down? No. So we need to be thinking on a different platform. We got to get away from saying, oh, I got to just get the numbers right. So if you get the numbers right, you will meet the standard of care. And that's fine. But it's really, standard of care is getting a C. That's it. Maybe a C plus, but it's not even a B minus if you were being actually graded. So it is okay, but it's not what we should be doing. So it goes into now the next phase to say, okay, what is the right care and how do we define it? And we talked about it earlier today. And really the story is more personal to me than anybody else, is that had I known what I know today, my 83-year-old dad who recently passed away would be here today for another 10 years. His primary care doctor, great guy, he managed all the numbers perfect. A1C is great. PSA is perfect. This number is great. LDL is it. Everything is, he managed numbers. So by the time he finished managing the numbers, 4 years ago, he was on 13 different medicines. Each one managing another number, but it looked good. On paper, he looks amazing. So if you really think about it, we didn't do anything but just control the numbers. That doesn't mean you solve the problem. The problem is still there. It's like the 80% of the iceberg, the tip of the iceberg is there, 80% of it is on the bottom, right? Underwater. So it's very similar to this. So earlier, we defined right care, and we say that really we as clinicians need to look at every patient that walks in that door and treat them like they're your brother, sister, mother, father, sons and daughters. If you do that, that's the definition of right care. How you define it in different ways. And it doesn't really matter how you define it, but at the end of the day, that's how I define it, right? 2 o'clock in the morning, I don't have great adjectives in my head, but I need to be thinking, how would I treat this person if this was my mom? That's your litmus test, ultimately. If you can go home or put your head on the pillow and say, yeah, I would have treated my loved one the same way, then you did right care. Even though it may not have the best outcome, you did the right care. So when we were talking about this earlier, is that we're only and always about the patient, and we promise to always fight for their greatest good. And it all makes sense. That is exactly what we're saying, right? If it was your mother, father, brother, sister, son, or daughter, how would you treat them? That's the exact definition. So over the years, we talked about acute, chronic, and when we first started out the clinic models, it was really an urgent care. All the employer health clinics were originally urgent cares. And even if you look at the oldest model that was ever out there, the Henry Ford system in 1914, it was an urgent care. And then it evolved to more and more and more and more to become a full-fledged clinic, hospital to manage Henry Ford employees and their dependents. That is the first clinic model that replicates us that I can recall or in history, 1914, Henry Ford, Detroit. So everyone started with acute, you get them in, you engage them, try to figure out how do we do chronic disease, but then we need to go one more step further and say, what's the next stop? Really, chronic disease management is great, but the real reality is we need to go deeper and find out, can we actually get the root cause? 9 out of 10, if you spend enough time, you will know what the triggering points are. People will say, oh, well, he's got bad genes, right? So, like, I have bad cardiac genes because a lot of folks in my family have cardiac issues. I don't smoke, I don't have hypertension, I don't have diabetes, my lipids are fine, I don't take any medicine, but I have bad genes. So it's like, tough luck, Patel, you're stuck with bad genes, but that's not true. That's what we've been told, that we can't modify this. You can modify. I always told my patients this. I said, you can modify this, you can't modify this, you're stuck with it. I've been telling them wrong. So really, it's like loading a gun, and the loaded gun is there. Now, there's triggering factors that's going to trigger that. So if you can avoid the triggering factors, even though you have bad genes, you're not going to trigger a bad event. So the point of this would be to say, even if someone's got bad genes, it's not okay, but it's treated as loaded gun. Make sure more of the stressors are eliminated. And if we can do that, then it's not going to go off. And that's why a lot of the folks will say at some of these institutions, and some of them are out there, very, very attractive models are out there that say, we will reverse your cardiac risk factors, we'll assure you will never have a heart attack. If you do, there's some really good promises being made, and I really think there's value to that. When you look at it deeply, and what they do is really they dissect the patient as a whole and not just obviously the risk score. And so I'm going back and saying, look, when we're talking and looking at our patients, we need to say, ask for the why did this happen, not what happened. Blood sugar went up, lipids are up, your sugar, A1C is up. That's the what. That's the result of something. So you need to say, why did it go up? What triggered this to go up? And then you can try to figure out the triggers. And I can almost guarantee you that the triggers will be a handful of triggers that are about 8 triggers. There's about 8 triggers that's going to trigger these things. So if we can manage these 8 triggers, and we know the 8 triggers, but the question is, how do we manage them, right? That's always a dilemma. But we need to know first, then we can tackle the problem. Right now, we're just saying, I solved the problem. The sugar was 420, now it's 120. A1C was 8, now it's 6.2. I'm a great clinician. And that's what we're stuck with that. So we need to kind of dissect out and then treat the why and not the what, right? Of course you got to treat the sugars, definitely, but you got to go back and treat the root cause. Is the problem is so big, so we shy away from it because it's just too big to attack. So we need to break it down in bite size. That's going to influence what we do tomorrow. Because you guys are the spokespeople at every one of our locations, every one of the medical centers. What you say do, they watch. They meaning the nurses, the secretaries, the MA, the assistant, they are watching you. We forget the power of the white coat. They are watching you. You are the lead for that place.